5, 4, 3, 2, 1. Blast off. Hi, this is Dr. Richard K. Bernstein with the October 2021 edition of Dr. Bernstein's Diabetes University. Before we start answering questions, I want to go through a few little news reports that may be of interest. A number of people have asked me if the new COVID-19 home test kits are accurate. And I'm not an authority on this subject, so you have to really get your information from newspapers, television, scientific literature. Here's an article from a recent edition of the New York Times that has the headline, "At-Home COVID Tests, Valuable if Used Right." And basically what it says is that they're not 100% accurate. There's some false positives and false negatives. However, if you think you've been exposed to someone with COVID, you should check yourself, let's say, every other day. And if you see a trend, that is, the second test is more positive than the first test, and the third test is more positive than the second test, it's likely that the system you're using is accurate. They also suggest switching from one home test kit to another, and if you get the same results on both, the results are likely to be correct. That's all I know, and I don't know it for sure because it's based upon what I've been reading, and what I've been reading can keep changing. The next little bit of interest can be very significant, and it's a report from researchers at Vanderbilt University. They did some studies on rodents, that's rats or mice, and discovered that if they block the receptors for glucagon, then the alpha cells in these rodents that make glucagon, many of the alpha cells can be transformed into beta cells that make insulin. So this is one of the more hopeful studies that I've seen. Now, what I've seen is what looks like a press release. I don't know if the final results have been published in a peer-reviewed journal, but if it's really possible to convert alpha cells to beta cells, there may be a cure for diabetes where there's a deficit, at least those forms of diabetes where there's a deficit of the cells that make insulin. Now, you don't want to, in reality, on a human, block the receptors for glucagon because that might cause other problems, but at least it shows that there is a way of getting the alpha cells to transform to beta cells. This is an article from, I believe, from the journal Diabetes Care, and it says, comparative effects of proximal and distal small intestinal glucose exposure on the production of GLP-1. And it sort of contradicts something that I've been saying for years. For years, I've been saying that if you eat any kind of nutrient, even very low calorie stuff, low carbohydrate stuff, that your blood sugar, that your intestines will make GLP-1, which can indirectly raise your blood sugar. And I've pointed out that just the mass of food, a lady who ate a whole head of lettuce, even if she ate a quarter of a head, her blood sugar would have gone up if she were type 1 diabetic. And I keep saying, once the food hits your duodenum, which is the upper part of the small intestine, called the proximal part. But what this is saying is that the production of GLP-1 begins when the food gets to the distal part of the small intestine, the far part. And I didn't realize this, so what I've been saying may have been incorrect, but it would appear from this article that the blood sugar doesn't go up. That is, the incretin effect, or what I called the Chinese restaurant effect, doesn't begin until food gets further down in the small intestine. Now, an article that absolutely surprised me. It says, is revascularization warranted in patients with intermittent claudication? Now, this leads to a fairly lengthy but very interesting story that I'd like to tell. Intermittent claudication is a condition that accompanies long-standing diabetes and is caused by poor circulation in the lower extremities, the legs. Patients describe it as, when I walk a block, my legs get tired and I have to stop and rest. And if I rest for 5 minutes, I can walk another block. That's a typical statement of someone with intermittent claudication. Now, it's common practice for surgeons to do bypass surgery on arteries in the lower leg in order to make it easier for patients to walk without having to stop. Now, when I was a medical student, actually when I was an intern, I got special dispensation to spend a month with the world's authority on the diabetic foot. His name was Heinz I. Lippmann, and he was the founder of the Peripheral Vascular Disease Clinic at the Albert Einstein College of Medicine. And I ended up working in that clinic a day every week for 30 years, and I became the director of the clinic. And when I spent this month with Heinz, we visited a second clinic that he had at another hospital, and he would have clinic once a week. And I went with him the first time, and I saw how he examined patients and the things that he did. And we come back the second week, and he asks the nurse, "Where's Louis?" who was one of his patients who would come back with a certain frequency. I think he was on the list of appointments for that day. And the nurse said, he went to, and she gave the name of the hospital. Why did he go there? Well, the surgeons came around looking for patients, and they said that he had intermittent claudication, which it said in his chart, and they took him to the hospital, at which point Heinz started to weep. He said, and the tears came out of his eyes. He says, "I've been treating him for years. he's practically a friend. They're going to kill him. And indeed, over the course of time that I spent in this clinic, I would learn of patients that died after what was called a Fempop Bypass, where they would take either a vein from somewhere else in your body and put it from below your knee to just above your knee to conduct blood, and therefore relieve the impaired blood flow to the area. Or they might even use a plastic vein in those days. And why was something bad happening? Well, these people with intermittent claudications had live legs that worked. They were able to walk. Now, why were they able to walk even though a major artery may have been blocked? Because that blockage of the artery occurred very slowly over a period of many years. Could have been 20 years, could have been 50 years. But as the flow through that artery slowed down, the patient would make collateral vessels bypassing the blockage. If this is the blockage, they made small vessels that would bypass the blockage and therefore keep the leg alive and enable the patient to continue functioning, if not at the full ambulatory rate that he did before. Now, what happens if you artificially bypass that artery in the manner that I just described? As soon as you relieve the pressure in the collaterals, they close down. So they're on the operating table. As soon as there's good flow from the upper part of that artery to the lower part, the collateral is closed down. And these bypass grafts, because they're not perfect, they cause turbulence. And sooner or later, the graft itself closes up, a clot forms in the graft itself. And there are no collaterals. So now you get a sudden blockage of a Fempop bypass graft and no collaterals. You have all of a sudden a cold, dead leg. And the only solution would be to do another bypass graft right away. That is to find a vascular surgeon who can immediately get an operating room and rapidly put within a short period of time, put you in for another bypass graft. And that just doesn't happen. So what happens is patient shows up with a dead leg that has to be amputated. And the statistics on amputations in diabetics is such that these patients can die within 6 months to 6 years from complications that related to the amputation. So here we have, in a major journal, a study of people who have had these bypass grafts and the fact that they don't survive very well. Lo and behold, here I was shouting about this, or Heinz was shouting about it 40 years ago, and I've been complaining about this for years, probably in one of my videos. And lo and behold, finally someone does a large-scale study and comes to the same conclusion. Okay, now we'll get on with the questions. But before we deal with the questions, I have to remind you that my answers are strictly guesses. I can't possibly get a complete medical history, family history, etc., of the person who asked the question, list of medications he's taking, etc., etc. So all I can do is guess. And the purpose of having questions is to be able to educate the general listenership, not necessarily to solve the problem of this individual, because my answer may be totally wrong for him. So you ultimately have to rely on what your doctor tells you. Or if you don't find that that sounds adequate, you have to find another consultant. First question, do you have any thoughts on the Omnipod? Well, the Omnipod is a little reservoir that you fill with insulin. You inject the insulin into the pod and you put it on your skin, and it has a little microscopic cannula that through which insulin is pumped under the skin into subcutaneous tissue. And this pumping rate can be controlled from a smart telephone, portable phone, and they have, it's like an insulin pump. They have algorithms that are based on incorrect hypotheses, such as only carbohydrate raises blood sugar, other foods have no effect on blood sugar, etc. The Omnipod can save you a lot of work in measuring blood sugars, measuring doses of insulin, etc., but it gives you only very small net results. So if you take a patient who's doing nothing to treat his own blood sugars, letting the Omnipod do it will be better than doing nothing, but certainly not comparable to the many tricks that you have to learn when you read my book, Diabetes Solution. Can low blood sugars cause damage too? Severe hypos aside, can having low blood sugars cause problems? Well, it would depend on how low and for how long. For example, if your blood sugar, and this depends on the individual also, and the history of how high their blood sugars have been. For example, some people who have had blood sugars, let's say, around 180 most of the time, you suddenly control their blood sugar, they'll get symptoms of hypoglycemia even when their blood sugars are still high, let's say around 130, and they might get very hungry. So they might then overeat and make their blood sugars go high. So one problem is that you can end up craving carbohydrate and overeating. Another thing that can happen is what happened to me. You could get fired from your job because you yelled at the boss. So that's another complication of low blood sugars. I don't think that there are any studies, at least I can't recall having seen any, that look at blood sugars that are low but not low enough to cause loss of consciousness. And this questioner is asking about that kind of blood sugar. And I don't think anyone has looked at this. So I really can't give an answer. But it can get you into trouble. You could end up crashing your motor car. I know of one patient who who never checked his blood sugar before driving, or I should say at least on one occasion he didn't, had a low blood sugar, hit another car and killed 2 people. So those things can happen. What do you think of the idea that most, if not all, autoimmune diseases start because of intestinal permeability? Well, I'm the wrong guy to ask about that because I don't know about all autoimmune diseases, and maybe you should talk to an immunologist. But the intestines are normally permeable, and there's constant communication between the microbiome, that's the bacteria in your intestines, and the rest of your body through the endothelial barrier of the intestines. Chemicals go in and out, back and forth, and there may even be organisms going back and forth. So I've not read of anything indicating that the normal permeability of the intestines causes autoimmune disorders, but it may well. We know about peanut consumption in early years, preventing peanut allergies and so on. So there's a possibility that there may be some sort of relation. What are your thoughts about when diabetics, especially very long-standing diabetics with complications, should get the COVID vaccine booster? Should they be able to have it sooner than 6 months? I really don't know. I know what's advised on television, where they'll interview authorities, and it would seem that many of these vaccines start losing their efficacy perhaps after 3 or 4 months. So maybe there's justification to not waiting the 6 months, but you really should keep up with what the authorities are saying. Again, I'm not an expert on this. Not only that, you may find that the instructions vary from week to week. My wife is a type 2 diabetic. She's 64 years old and has been dealing with the effects of diabetes for about 30 years now. So she's sort of a survivor. She's on insulin and metformin. Recently, she had a C-peptide test, value of 0.6. We're wondering if there is any hope of this measurement coming up and possibly her beta cells recovering. Well, first of all, an isolated C-peptide, by the way, is part of the insulin molecule, of the pro-insulin molecule, which gets broken off when proinsulin gets converted to insulin. And there are equal, at the time that insulin is being secreted, the body is making or releasing equimolar amounts of insulin and proinsulin. I'm sorry, of insulin and C-peptide. Not only that, the more insulin you make at that point in time, the more C-peptide you're going to make. And the higher your blood sugar, if you're making any insulin, at that moment, the higher the C-peptide. So if you go into the lab with a blood sugar of 65, your C-peptide may be undetectable. You might not be making any insulin. Whereas if you go in with a blood sugar of 130, your C-peptide may be elevated. So without knowing what your blood sugar is at the time of the measurement, you don't even know the meaning of the C-peptide value or the significance. Not only that, you do something to raise your blood sugar, how long does it take for the C-peptide to start being released? So there's a time frame problem in here. So it's very hard to get information of value by taking an isolated C-peptide test. It would probably require many tests at a variety of blood sugars to have some sort of valuable information. And can your wife do anything to bring up the C-peptide level? Not that I know of. We have seen insulin production increase in newly diagnosed diabetics who rapidly normalize their blood sugars because we know that high blood sugars are toxic to the beta cells that make insulin. What do you think of the new consensus definition for type 2 diabetes? Oh, for type 2 diabetes, no. For type 2 diabetes remission, an A1C less than 6.5%. I think we've talked about this before. An A1C less than of 6.5 is a blood sugar around 150 or 160. So it's somewhere close to double normal. Now the ADA would call that a cure. But you guys and I know that that's not a normal blood sugar. It's not a cure. So there have been many claims of cures or the diabetes normalized because with the help of medications or insulin or whatever, they get the A1C down to 6.7, and it's a claim that's not valid. 6.7 is not a normal blood sugar. Mostly we eat low carb, but I let my 7-year-old son eat whatever he likes on the weekends. His last A1C is 5.9%, which is around an average blood sugar around 135. It's hard to cut back his carbs, and the doctor says under 6% is his best patient. What do you think? Well, I've heard from patients, usually listeners to the video who sent in questions, who have been told that when they have an A1C of 5.9, they're the worst patient, because most of the endocrinologists, at least, like to see the blood sugars very high, especially in children. So you may be the best patient for some doctors, or your son may be the worst patient for other doctors. What electrolyte supplements should I try if I find myself constipated? First of all, I doubt that electrolytes relieve constipation. You may be thinking about advice I've given for people with diarrhea, that if they're losing a lot of fluid, they may need electrolyte replacement. But that has nothing to do with constipation. I usually, for people with long-standing diarrhea or vomiting, well, vomiting, you can't hold down oral fluids. That's another story. It's covered in my videos and in my book. But low, rather sugar-free commercial electrolyte solutions like Powerlight, sugar-free Powerlight, or Powerlight Zero, or Gatorade Zero would be possible electrolyte solutions for diarrhea. Please comment on ApoB. Should I be getting it measured? What do I do if it's elevated? Well, ApoB is one of many measures that you could find in the blood that suggest a risk for heart disease or cerebrovascular disease. But it's just one of many. I just started with a new patient on Skype, a virtual patient, and I looked at many bloodborne risk factors, and as I recall, his ApoB was fine, but he had high fibrinogen, high C-reactive protein, elevated D-dimer. So there are many things that you could look at, and the main thing that you could do about them is normalizing blood sugar if you're diabetic, because what we see is that many of these risk factors diminish when we control the blood sugars. Now, there's one other thing that might have an effect on some, but not necessarily all of the risk factors, and that's exercise. But you have to be very careful about the kind of exercise you do, because if you're already at risk of a heart attack, you might give yourself one by doing the exercise. Reminds me of a friend of mine many years ago, who was older than I, but I was maybe in my 30s then, maybe in my 20s. His name was Maurice. He lived in Chicago, and he had a little bit of pain in his chest. So he decided he was going to test it, and he ran up and down the stairs and dropped dead. So depending upon your age and how long you've been exposed to these risk factors, exercise can be dangerous, and you should consult a cardiologist before you embark on any new exercise. My daughter is following your protocol with great success. She is going to go away to college and wants your advice and ideas about social drinking. Oh boy. Well, this brings up another interesting story that might be worth listening to. I belonged to a fraternity when I was in college, and they used to have beer parties every Saturday. And they'd order a barrel of beer, and the guys would all get drunk, and I might have one glass because I knew I was type 1 diabetic, and I knew that intoxication could get confused with hypoglycemia. And I frequently could feel the effects of hypoglycemia, know my blood sugar was low. I need something to bring it up. So I was fearful of consuming any alcohol. But there was one time that there was a block party at Columbia University, and we were supposed to put on a show. And I don't know why I can guess why I was asked to sing a song, because I knew all the songs of Tom Lehrer, who was a professor of mathematics at Harvard, but he got interested in hallucinatory drugs and became a nightlife pianist, singing songs turned on by the hallucinatory drugs. And I was asked to sing a song which was called the Old Dope Peddler. And we're rehearsing in the fraternity house all day, and I have a sore throat. And my mother used to give me turpin hydrate with codeine to treat sore throats, because the pain would go away. So in here I'm supposed to be singing, and we're practicing. So I have a 6-ounce bottle of turpin hydrate and codeine. And by the time we have to go to the block party, I've finished the whole bottle. And I can barely walk because codeine is a narcotic. And they help me onto the stage. I sing my song. In my pocket, I had a handful of cigarettes that I threw out to the audience at the end of the song. There was supposed to be marijuana. And I don't remember anything after that. Fortunately, I guess I didn't develop hypoglycemia, but I woke up the next morning in my bed. I don't recommend drinking while at college. I think it can be extremely dangerous. You've heard stories about what they've done with both boys and girls in college, where they have the drinks that have been doped or modified. Girls have been sexually abused, and certainly if you have diabetes, you don't want to be even exposed to the liquor because of the hazards. What I would advise is that if you're going to college, you go to a college near home so you could go home, be home at night and near your parents, that you wear a continuous glucose monitor and have several followers. That's people who can read your monitor from their cell phones, and that your parents could be monitors, but also your friends at school. And usually friends at school are very anxious to be helpful to diabetics who have the potential problems that we all know about. I think, and certainly you should have a roommate if you're living at school, and the roommate should be a follower, and if you have several roommates, they should all be followers, And you should tell all your friends that you're type 1 diabetic and let them know that drinking alcohol is potentially dangerous. And a little tip, you may have heard the ADA guidelines with regard to alcohol, where they don't tell you to avoid it completely. They say to only have it at mealtime, as if that's the safest time. And it's just the opposite. That's the most dangerous time, because alcohol can turn off the ability of the liver to break down glycogen into glucose for the purpose of raising blood sugar. So it can also turn off gluconeogenesis, which is performed by the liver with certain enzymes, where you break down amino acids from your muscles or from the meal. Let's say that you're eating a high protein meal, you're taking insulin to cover the conversion of some of that protein to glucose. But if you have too much alcohol on board, that protein will not be converted to glucose, and therefore your insulin dose will have been too high and you'll get hypoglycemia. And I've experienced this firsthand many, many years ago, 50 years ago. So you have to be very careful, and you should really avoid the alcohol altogether. I have two questions about regular insulin. First, can I use it for intramuscular corrections? Yes, you can. That will speed up its action. And second, where do I inject the R when I want it to work slowly? For example, for a meal. You inject it in subcutaneous tissue. That's where mealtime R should be injected, and likewise your basal insulin should be injected in subcutaneous tissue. Since you don't know these things, I suggest you read my book, Diabetes Solution. Can you walk us through some examples of how your patients do? I'm specifically asking about overweight type 2 diabetics. How long to get blood sugar under control, and how long to lose a significant amount of weight? Well, it really depends a lot on the individual. I find it hard to find two individuals with the exact same time frames. One extreme case was a guy I talked about in my first book, who was not a patient of mine, he was a friend of mine. And he had gained 100 pounds. And knowing me, I had found a blood sugar meter and was checking my own blood sugars. I had not at this time popularized blood sugar self-monitoring. I had just stumbled on it, but he started measuring his own blood sugars, and he got the pharmacist to sell him insulin, which he injected himself. In those days, you did not need a prescription for insulin. So he was taking 100 units of insulin a day on his own. And finally, he called me up and said, no, he didn't call me up. The pharmacist, who is also a friend of mine, called me up and told me what was going on. So I called my friend and I told him he had to lose weight. I referred him to a physician I knew who could help him lose weight. And he lost 100 pounds and didn't need insulin anymore. I guess he was cured. And it probably took about 6 months. When I have an overweight patient who's cooperative, does everything they're supposed to do, we usually lose about a pound a week, or I should say a half pound to a pound a week. I haven't seen dramatic reductions like 5 pounds a week or so. None of that. And I do have one patient who only recently stopped overeating. And the trick for this particular guy, he was only overeating at dinner. And what would happen is his wife would make a dinner and would make more than he needed. And it would be out there in a bowl on the table, and he'd eat everything. Well, he stopped getting homemade meals and went out and bought low-carb frozen dinners and would eat 2 low-carb frozen dinners per night. And the rest of the frozen dinners were all frozen, so he couldn't grab any more. And so far, that's been working. And he's certainly losing about a pound a week. And we'll see what happens, whether he can stick with this. But it's highly variable. I have one lady who did very well until she had a knee injury and shoulder surgery and could no longer exercise. And her husband is also a diabetic, both type 2 diabetics, both lost a lot of weight, and she is still overweight because she can't exercise. So it's a highly variable thing. The experiences, the histories of these people vary considerably. After observing things like the government food pyramid, the high carb protocol for diabetics, the push for statin drugs to lower cholesterol, I was very cautious about pharma government access and their recommendations. How do you feel? Yeah, I believe that too. I'm curious if looking back on your life, you feel like your longevity and health was worth giving up all the high carb goodies. Would you do it again? Maybe I'm lucky in that I'm not a big eater. And also I was running scared. I was dying of the complications of diabetes, had advanced kidney disease and so on. And I never got to meet the nude lady, but I have the opportunity to wear this medal if I so desire. And we're going to show you a video of my receiving the medal, and I was permitted to speak for 3 minutes, and you'll hear what I said. So enjoy the video.
Next, for the 75-year medal presentation, we given to Dr. Richard Bernstein, who's actually from New York, and we certainly are very honored to present this medal to Dr. Bernstein.
Thanks for the medal, Dr. King. I'd like to say something about the turning point in my life. I had diabetes for 24 years when I was an engineer working for a company that made clinical laboratory equipment. I had many of the complications of diabetes, including advanced kidney disease, and my main concern was the effect that my frequent hypoglycemic episodes was having on my family. I was very fortunate in that I stumbled on a device that was used by the emergency rooms, a brand new device, to tell unconscious drunks from unconscious diabetics at night when the laboratories were closed. This was the device, a 3-pound meter the size of a Bible, and I cut off the cord, created a battery pack so I could carry it around with me, and this replaced this, which was a urine test kit. Now that I knew what my blood sugars were, I was able to figure out what made them go up, what made them go down, how much a unit of insulin would lower my blood sugar, how much a gram of carbohydrate would raise my blood sugar, how much protein would raise my blood sugar, and I ended up walking around with normal blood sugars around the clock. It occurred to me that there were other diabetics out there with the same problem, and I wanted to help them try to get the medical establishment to approve blood sugar self-monitoring and multiple insulin dosing, which I invented. We called it basal bolus insulin dosing, and was unsuccessful. So with great effort, I ended up getting into medical school. While I was in medical school, I wrote the very first edition of this book that's now a bestseller in the diabetes field, and we had a total of 9 editions. I am 87 years old. I work a full schedule, patients 4 days a week. Fridays are doing videos, writing, and keeping up with the scientific literature. I can exercise way above the theoretical maximum heart rate for my age, and have no new or advancing diabetic problems. Examining me, you wouldn't know I was diabetic. It comes with a very heavy frame, so I have to have a big nail to hold it, and I'll show it to you up close in a minute. And you can see the lady. There she is. So I'm supposed to wear this around my neck most of the time. Now, that medal is apparently a statement that I'm alive. And why am I alive? Because I'm doing just the opposite of what the guidelines advocate. Okay. Oh, wait, our next visit. I'll put this on. Okay. Well, thanks for watching Diabetes University. Our next edition will take place on Wednesday, November 24th. Look forward to seeing you then. Thanks for watching.